what resources would you recommend for someone who has the diagnosis of diabetes?
I love, a lot of the things that the American Diabetes Association puts out, right? So I think they've got really good recipes there. They've got kind of the idea of what a healthy plate looks like. I love the idea of tracking. I love tracking things. I love writing things down because I think when you see things in front of you, you're more likely to be in tune to them and to make changes based on those things.
Hi, this is the Care Room with Dr. Cindy. Welcome. It's a space that was created just for you. I'm your host, Dr. Cindy, and this is a chance to get up close and personal with me. We're going to talk about the things in medicine that matter to you. We'll talk about the questions you've been carrying. We're going to have some honest conversations. We're going to hold space for joy, struggles, and everything in between. It's care that goes beyond the exam room. Care you're going to take home with you, whether you're listening while you're driving or you're listening while you're exercising. I promise that it's going to be care that's rooted in truth and a deep commitment to walking with you every step of the way. I'm glad you're here.
Hi, everyone. Welcome, welcome, welcome. Welcome to another episode of the Care Room with Dr. Cindy. I know I say this every single episode, but I have an amazing doc with me today. She is a boss in her own world, a boss in our world. It's the amazing Dr. Brittney Anderson. And she has so graciously decided to honor us with her presence. She is a family doctor in Alabama. She owns her own private practice called Anderson Family Care. Did I get that right? I did. Anderson Family Care in Alabama. And she does such great work. She works with med students. She works with doctors, coaching. She is just doing it all. She has a new health planner. Like, who comes up with a health planner? Who does that? And we'll talk more about that, guys. It's an awesome gift if you were looking for something
Yeah.
that will help a family member, keep everything together. But we'll talk about that later. But first, before we get into everything, let her introduce herself.
Awesome,
Dr.
Dr.
Anderson,
Cindy.
it's all
Yeah.
yours.
Thank you, Dr. Cindy. It's so great to be here with you. I love getting to watch and listen to you, and I love all the great things that you're doing in practice and how your heart is really in helping patients become healthier and living their healthiest lives and being their best selves. And you are wonderfully
Thank you.
fabulous in doing it. So thank you for having me today. Like you said, I'm Brittney Anderson. I'm a family medicine doc in private practice in Alabama. In addition to the practice, just working some other things with the overall goal of helping physicians find their joy in medicine and often also helping patients live their best, healthiest lives. And so I love getting the chance to talk with docs like you and just people in general who are doing things like this to bring education awareness to our folks. So thank you for having me.
Absolutely. I wouldn't have it any other way. Thanks for being here. But we have so many questions for you. I know that, you're a family doc and you're doing all of these great things. But today I wanted to talk to you about something that's pretty common. It affects a lot of us. It affects a lot of, if not us, our family members. And that's the topic of diabetes. From your experience, can you explain to us and, kind of for those listening, kind of just break it down. What is diabetes? And we'll take it from there.
Yeah, absolutely. So I'm excited to share this topic with you. We were talking about it a little bit before, and I was saying how, I practice in Alabama, in rural Alabama at that. And diabetes is something that I
Yeah.
see all the time, almost too commonly see diabetes in my practice. And, my a lot of my patients here in Alabama call it the sugar. And sometimes I call it that for them too, because that's the way I make sure my patients understand what I'm talking about. And we use the term sugar more than we use glucose sometimes. But you're exactly right. I was looking at a stat earlier, and 38.4 million people in the US have a diagnosis of diabetes. And the basis of the definition for the diagnosis is really just our body's inability to regulate how much glucose we have in our bloodstream, right? And whether that is because we are born with an issue of our pancreas so that we're not able to release enough insulin to kind of counteract how much glucose we have, or if it is a matter of our pancreas. I tell my patients maybe sometimes it's just that your poor pancreas has given all it can give, right? If the job, one of the large jobs of the pancreas is to help produce insulin, then maybe we've just overworked it. We have given ourselves too much glucose over too long a period of time, that our pancreas just can't do the work that it needs to do. And so, while there certainly are some people who are born with issues that cause, maybe type 1 diabetes or other problems where they can't produce enough insulin for their bodies, largely it's lifestyle related, right? And related to the things that we're putting in our body, the things that we're not doing enough of for our body. There certainly is a genetic component to it. I was talking with a friend on my podcast recently who said so much of things that we put on our family, and we say that things run in our family, and maybe it's actually that our family doesn't run. And she said it on the podcast, and it was like the best thing ever. It made so much
Yes,
sense.
yes.
So many times we try to put things to genetics when we really got to take a step back and say, okay, what am I doing? What changes can I make to get rid of this? Me too, because when she said it on the podcast, I was like, oh my God, I'm going to say that a million times more
Yes.
because it was so good and so right.
That's amazing. That's amazing. And Dr. Brittney, Dr. Anderson, there are different types of diabetes, right? Can you touch on that for
Yes,
us?
absolutely.
Yes.
So your type 1 diabetes, which one that I mentioned before, where generally, we see it in early childhood, see it at birth. We even now are sometimes seeing it in folks as we get a little bit older, but it is where your pancreas just truly doesn't have the ability to release insulin as needed. And then there's type 2 diabetes, which is more of an insulin sensitivity. And so again, I kind of commonly describe it to my patients sometimes. It's like your pancreas is just pooped, right? It's done as much as it can. It can't produce insulin, and that's what produce enough insulin, right? And that's where medicines, when we start to think about how some of the medicines work that we use to treat diabetes, a lot of those medicines work in a way that they help to kind of turn that pancreas on, increase some of the
Right.
insulin production from the pancreas, increase our cells uptake of that insulin. A lot of those pills that we take by mouth, and then there's some medicines. Sometimes we get to a point where our pancreas still, again, in type 2 diabetes, just can't do it anymore. Then you have to give yourself insulin. So you have type 1 diabetes, you have type 2 diabetes. We also have gestational diabetes, right? And that is a diabetes that women are diagnosed with during their pregnancy. And a couple things to think about there. I mean, it can be isolated just to the pregnancy itself. But when you have gestational diabetes or diabetes in your pregnancy, then you really have to be careful that you're screened later in life and that you're regularly being seen, regularly getting that follow up done to make sure that you don't develop type 2 diabetes later. So that's one too that we commonly, when I'm seeing new patients in clinic, it's not just, what are your family history, but really making sure that we know those patients' personal histories, especially women get into a history of, did you have this, and this going on in your pregnancy?
Right, right, right. That's so good. Thanks for breaking it down for us like that. So, for the patient who's like, man, you guys just don't want me to eat my sugar. I love my grandmother.
Yeah.
She loved her cake. She was like, that's the one thing you guys are taking away
Yeah.
from me. I need to have my cake, especially around Christmas time. We use this like this. It's called it's almost like a fruit cake kind of
Mhm.
with alcohol in it too. Oh my god, she refused. That
That
was
is
a
so
one thing.
fun.
So for the patients who are like, man, I can't give that up. You guys just want to take away the good stuff. Can you explain why it is important that we monitor our sugars, the sugar, as you say, we keep that under control? What happens if that is just left uncontrolled?
Yeah, so I have a patient. I'm going to use a patient of mine as an example that I saw earlier this week. You and I are recording this on Thursday. Saw her earlier this week, and had a new diagnosis of diabetes. And so I'll see patients in clinic. I was seeing her. We were just getting her regular labs, right? We checked just a regular glucose level in her lab. I hadn't checked an A1C. I wasn't checking A1C. We were just checking her regular labs. The lab came back showing that her glucose was really high. It was early morning when I saw her. I know she was fasting when we took the lab, and so her sugar level was way too high for her not to have eaten anything that day. So we
Mhm.
called the lab and said, "Hey, you have this blood from our patient. Can you add an A1C to it?" So an A1C is that blood test for your audience, a blood test that looks at how much sugar has been attached to your red blood cells over a period of time, usually 90 to 120 days, which is the lifespan of our red blood cells. And so that A1C comes back high. And when I see that, Dr. Cindy, there's so many things in our office that we get back in labs and we call our patients on the phone and say, "Hey, here are your lab results. We're going to do this, this, and this." But with the new diagnosis of diabetes, I bring those patients back in the clinic. My nurse calls, she will go ahead and say, "Hey, your labs show that your sugar levels are really high. Dr. Anderson wants to see you back in clinic and talk about it. Can you come in one day this week?" And for our patients who can't, I'll get on the phone, have a phone conversation with them. But for the reason of your question, I like to have this discussion face to face because I tell them we are looking at a new diagnosis. Now is the time to turn this ship around, right? And so
Yeah.
I go right into that discussion that you're saying. And I don't do it as a scare tactic. My goal is not to scare my patients into improving their blood sugars, but it really is to educate them and show them, hey, if we don't, change course here pretty quickly, these are the things that can happen. And those things, I mean, diabetes can affect your entire body because it affects your blood vessels, can affect your blood vessels, your nerves. And so, going head to toe, we talk about some of the vision changes that can come, specifically what we call diabetic retinopathy, which is one of the leading causes of blindness in the United States, right? And so that is where our blood sugar, our blood glucose has just been so high for so long a period of time that it starts to affect those vessels in our eyes. And so we talk about how if we can't get our diabetes under control, it can cause us vision issues, can cause us to lose our sight. We talk about the renal issues, the kidney issues that come if we have poorly controlled diabetes for a long period of time. And, when we start saying these things, almost everybody knows somebody or has heard of somebody who's had to take dialysis, right? And so I say, I know you know somebody in your family who's had to do dialysis. There are many reasons that people have to go on dialysis, but one of the most common ones is really poor controlled diabetes. And that kidney disease that can come with it is really really real. I talk about some of the like lower extremity things, and I'll say something like, maybe you've seen somebody who's had to get their lower leg amputated, and that may not have started under the knee, that may have started at their foot, that they had an ulcer on their foot, but because that diabetes had affected their blood vessels and their nerves so much, maybe they stepped on a rusty nail and couldn't feel it. And next thing you know, they had infection that was all the way to bone and they had to get an amputation. And so I say things like that. And to my men, I go there. I talk about erectile dysfunction that, we've
Oh,
got
you
those
take it
small
there, Dr. Anderson.
friend, I take it all the way there, and I'm telling you that all it takes is for you to have to bring that up to a man, whether it's talking about diabetes or poorly controlled high blood pressure, and you're gonna get a turnaround, okay? Because that is not what those guys want, and so I go there and we talk about those things, and I do it again, not as a scare tactic, but because I think it's important that patients understand this is what can happen, and then they've got free will to make whatever choice they wanna make, right? And
Absolutely.
I'm there to help and assist. But I do, and so again, I bring those patients into clinic, and we have that discussion in clinic. And sometimes I'll say, so this is what we have in front of us. You look at me, I'm looking at you. Is this something that you're going to say, Dr. Anderson, I don't want to take any medicines to treat this? Give me 3 months, depending on what the numbers are. Give me 3 months and I can turn this thing around. Or are you saying, Dr. Anderson, we need to start some medicines and get this thing under control? And regardless of which of those they choose, most times they mean it when they say it because I've laid everything out on the table for them. And I think that's so important. I know that you see the same in your practice too, and that importance of
Absolutely.
really talking to patients about what can happen.
Absolutely. Absolutely. We all see it. We all see it. I had in residency, I had an attending for guys, that's the doctors above you who are teaching. He always used to explain it as high sugars clog arteries, and then he would go into detail like you have those arteries in your eyes, and when they get clogged, that leads to blindness and your feet. And he's like he's really breaking it down. So that leads me to my next question. A lot of patients, they're scared that they have the sugar, they're diabetic, what can they expect in terms of a physical exam when they come to you
Yeah.
as a diabetic?
Yeah, so that's a really good question. First there's a sign in the room that says you have diabetes, take your shoes off. Like we are doing a foot exam. Go ahead. My nurses know it already. We're doing a foot exam for that very reason that I said earlier, right? Like what you don't want is to not have that sensation. I'll use my dad as an example, and I don't tell him that I said this, but I literally know this about my dad. But my dad at one time had really poorly controlled diabetes. It's much better now. It's great. But my dad, after retiring, was doing a lot more construction stuff, just kind of piddling around the house, and he had a nail gun one day and ran a nail from a nail gun straight into his thumb. No idea. No, other than seeing the nail sticking out of his thumb, did not know, meaning he didn't have that pain sensation to let him know what had happened. And so when we do the foot exams in clinic, what I'm literally doing is making sure that my patients have good sensation on the bottoms of their feet, the tops of their feet. I'm looking at their feet to make sure there are no ulcerations or anything like that. Because to the listeners, you may think, gosh, how does someone not know that they have a nail driven through their finger? Or how do they not know
Yeah,
that they have an ulcer on their foot? I guarantee you, people will
yeah,
absolutely lose feeling. And so those foot exams is a big part of it that maybe is a little bit different from what we do in our regular visits. But in addition to that, it's making sure you get a good heart exam, that you're getting a good physical exam, a good head to toe physical exam, but also making sure in addition to the foot exams that patients are getting regular eye exams too. So the guidelines
yeah,
surely at least once a year you need to be getting a dilated eye exam, a formal eye exam, not just looking at the eye chart and reading the letters off, but you need a formal eye exam where somebody is dilating to be able to get a look at those vessels in your eyes for that reason that you said, to make sure that there's not any damage to the blood vessels in our eyes. And so we add those things on, and that foot exam though is the big one. And I'm not, after my dad, you would think I do a hand exam now, but I don't. I may need to add that.
he's okay. Oh, he's okay,
He's
right? He
totally
didn't
fine.
lose any
His right thumb
digits.
is like twice the size. I mean, he had to use a pick line for a long time. It was a whole thing, and it was only by the grace of God that he
Yeah,
didn't lose that thumb, that digit altogether, because that happens again, because people will have infection and they will have serious injury and just not know it because they don't have that sensation.
yeah, yeah. So good, so good. Thanks for breaking that down for
Yeah.
us,
Yeah.
Dr. Anderson. So we're at the point where, we have the diagnosis, we had the exam. What are our options for treatment?
Yes. Several options. So one, again, the first one is lifestyle changes. And again, I'll get some patients who come in, and so we diagnose diabetes when your A1C. Remember, that's that blood test where we look at how much sugar is attached to our blood cells, excuse me, over the past 3 months. If that A1C is 6.5, boom, there's your diagnosis of diabetes. Some people will be 6.5. Some people will be 6.6. Those are patients, Dr. Cindy, that I say you've got options here. Of course, all our patients have options, but I say you got some real options here. You can say, Dr. Anderson, I know there are some changes that I need to make. If you give me 3 months, you have my word. I will come back in here in 3 months and my A1C will be lower than 6. And to those patients who, again, because I'm sitting across from them, who will look me in my eye and say that, I say 3 months is yours, friend. Go, like, go live,
Let's do
live your
it.
life. Go do it. And a lot of times these patients will come back and their A1C is improved, and willpower, mindset change, all those things alone have been enough. But then there's some patients who sitting across from me will say, Dr. Anderson, let me just tell you, I don't have any changes to make. Or either I don't have any changes to make, I'm already doing everything I can, or I just know that I'm not going to do these things, right? And
Right.
so, while lifestyle changes, eating better, exercising, all those things are number one. Number two is that we think about medicine options. And so I want to talk a little bit about those too. So the lifestyle changes, of course, I mean getting in some regular movement. So some regular movement, some daily exercise. And daily exercise, in my opinion, is not just I walk a lot at work, right? Because I hear that so I hear that all the time.
You sorry, Dr. Anderson, you are on to them. You know.
Oh, I'm reading them because I see it every day. My patients say, "Oh, Dr. Anderson, I walk all day at work." And I say, "Friend, that does not count. I mean, dedicated 20 to 30 minutes of your heart rate is staying up, not you're getting up and going from here to there. And, 30 minutes later, you're going from here to there. Like, I need you moving." And so that one, of course, is one. And the second one, again, is what we put in our mouth. When we're talking about those lifestyle changes, it's what we put in our mouth. And I tell people, right or wrong, I say look at avoiding white foods, right? So sweet foods, white foods, and watch what you drink. By white foods, I mean, white flour, white grits, white potatoes, white spaghetti noodles, white bread, all those things.
Like
So think
that.
about, shifting away from those. And if you just have to have that, instead of the white version, make it the brown version of it, right? Instead of white bread, do whole grain bread. Instead of white rice, do brown rice. Instead of grits, do oatmeal. So making some of those, starting to make those changes. And then, so the white foods, the sweet foods. Now, we're getting up on holiday season as we talk about this, and I'm in Alabama. My office, we literally had a pound cake cook-off in clinic last week. Like my
I saw
patients are
your
like,
pictures on that.
"This
Yours
is
was great, by
fantastic."
the way.
Oh, it was fantastic, actually. I amazed myself. But it is having that discussion with patients about sweets. So, that pound cake cook-off, we all made, my whole staff made pound cakes, and my mind was blown. I've never made a cake from scratch before, ever. My mind was blown at how much sugar I put in that cake. Like it's insane. And so
Yeah.
watching the sugar, the sweets, the little Debbie cakes, all the things that we love to eat, watching what we drink, thinking more about water than juices and sodas and sweet teas that everyone loves here in Alabama. And so really looking to make those change and getting more fruit and vegetables on your plate, right? So more fruit and vegetables, adding more color to your plate, and then having a size plate that makes sense. So we don't need these huge plates. Get you some 9-inch plates in your house and watch portion control. So lifestyle changes is big. And then there are medicines. And it can be
Right.
medicines that we take by mouth, some that are old and that we're used to, or, metformin is kind of the old tried and true one that people think of. But there are tons of medicine options that folks can take by mouth. There also is insulin as an option. So if you get to the point where your A1C is just too high, or your sugars are not controlled, or some reason you can't take the medicines by mouth, then insulin becomes an option. But now we've also got this really great option of those GLP-1s, right?
Yes.
Kind of that trial that we can do before we have to put somebody to everyday insulin, or, 3, 4 times a day you're having to take insulin. Maybe that once a week GLP-1 injectable like Ozempic or Mounjaro that we hear about. So we've got some options there.
We do have some options, and thanks for breaking that down for us, especially with this upcoming holiday season.
Yes.
Think it's okay. I have a lot of patients who, once they get the diagnosis, they start worrying, like they go
Yes.
to the other extreme, they
Yes.
become scared. Can you talk to us about moderation? Like,
Yes.
when can we cheat? Because it's going to happen, right?
It's gonna happen, right? And it's gonna happen, and when you plan for it and allow it and give yourself some grace in advance because you know it's gonna happen, then you don't send yourself down the spiral like you mentioned. So, I'll go back to, again, that pound cake cook-off we had in clinic, and I made a point to put a disclaimer under there that, yes, it's something that we're doing that's fun in our clinic, but we also wanna share the message that you don't have to get this diagnosis and decide that you can never eat things that you once enjoyed ever again. You can, but it has to be in moderation, right? If you wanted a little bit of a sliver of a piece of pound cake, or if you wanted white bread on your sandwich and not wheat whole grain bread, then those things are okay. It just can't be an all day, every day, this is my new normal? And so moderation becomes so important. And there's some patients, again, who look me dead in my eyes and say, Dr. Anderson, if I eat one M&M, I'm eating 100 M&Ms. You, friend, need zero M&Ms then. And so
That's funny. Yes, I agree. I
some
agree.
people have that. Some people have an addictive personality, and if that
Yes,
if that
they
is the
do.
sweets,
They
then they
do.
have
They
to.
do. And at least they're owning up to it and they're honest. Like, don't expect that from me. I
Exactly,
love it. I love it.
exactly. Yes,
So that brings me to my kind of final question. What resources would you recommend for someone who has the diagnosis of diabetes or any chronic medical condition and
yeah.
they want to keep track of, what they eat and like their appointments, their medications? Can you walk us through that?
Yeah, so the first resource I'll say for diabetes, I love, a lot of the things that the American Diabetes Association puts out, right? So I think they've got really good recipes there. They've got kind of the idea of what a healthy plate looks like. I love the idea of tracking. I love tracking things. I love writing things down because I think when you see things in front of you, you're more likely to be in tune to them and to make changes based on those things, right? And so, whether that is meal planning, so planning your meals in advance, that's one really good way to make sure that you don't go off the rocker with what you're eating. Having a place to track your levels. So, like if you do have diabetes, to track your blood sugar levels, something to write those down in. And then I think maybe what you were leading me in to talk about was this planner that I created, right? So I created a wonderful planner that I wish I had one close to me that I could hold up and show, but it's called a Healthier Planner. And I love a daily planner where I can get my days organized and know what I need and what I need to do tomorrow, remembering what I did 2 weeks ago. But I see so many patients in clinic who can't tell me who their different doctors are, who their dentist is, who their eye doctor is, who can't tell me what medicines they're taking, who come in for an appointment and have questions, but say, gosh, I can't remember those questions that I wanted to ask you. So I created a daily planner that is like our normal daily planner and added all those things in that I hear my patients day in and day out talk about and things that I wish they
Yeah.
would talk about if they don't, right? So there's sections there for them to plan their meal.
Do this. Come back with it next time.
Yeah, so there's a place for you to plan your meals for the week, and then right beside it, a place for you to make a grocery list. Because we also know that if you go into the grocery store with a grocery list, you're less like, and Little Debbie cakes are not on that list, you're more likely to not walk out of the store with Little Debbie cakes in your bag. So a place to make grocery lists, but also a place to track your history, your health history. So your own personal history, remembering when you've been hospitalized, what your surgeries are that you've had
Yeah.
before, your medications, a place to put them all, who started those medicines, why you take them, what pharmacy you pick them up from, a place to track your family medical history, what member of your family had what disease, a place for you to come up with health goals that you want to make and how you're going to reach those goals and how you're going to reward yourself when you hit those goals. And I think, the purpose of the planner is just to help people, again, like I said, live their healthiest lives. And I think we all have the means to make next year our best year ever as we get closer to
Yes.
2026. And one of the parts of
Yes.
living your best year is living your healthiest year. So I'm really
Yes.
excited to produce the Healthier Planner, and it's been fun watching people get excited about it with me.
Yes, I love it. Thank you, Dr. Anderson. I'm getting my mom one as a
That's
Christmas present.
wonderful.
Yes.
Thank you.
Hopefully this episode, because she listens to all my episodes. Hopefully this episode comes out after Christmas. Hopefully. But yes, Dr. Anderson, thank you. For our listeners who have been here, they want to find you. Where can they find you?
Yeah, so like you, I've got a podcast. The podcast is called Headed to Healthier. And saying just like you, just bringing information to the patients. My podcast more specifically looks at women who are 40 plus who lead really busy lives and have spent so much of their lives taking care of everyone else
Yes.
and have realized, hey, now it's time I've got to slow down, take care of myself. And so, we're all busy. We're taking care of children, taking care of our parents, have busy work schedules and social calendars, but it really is kind of pointing to some of the really preventive health and women's health type issues that we all face and see.
Yeah, guys, you heard it. Check out her podcast. Dr.
Yeah.
Anderson, it was such a pleasure having you here with us. Thank you.
Thank
Guys,
you.
I know I say it every week. You're very welcome. I know I say it every week, but we'll have another really awesome doc on with us. But until next time, take care.
Thanks for spending time in the care room today with Dr. Cindy. If you liked what you heard, please subscribe, share this podcast. I'm also on Facebook and Instagram. You can follow me there. Remember, you're not alone in this. There are doctors who do care. The information in this podcast is for educational and informational purposes only. It is not a substitute for professional medical advice, treatment, or diagnosis. Always consult your personalized healthcare provider for medical guidance.